So good morning. Today we're going to be talking about COVID-19 comeback, waves 2 and 3, feared as states open up. If you're looking to start hating on me for covering this item and you're expecting me to say don't do that and fear mongering, that's not what's going to happen. Just listen up and you'll see we're again reporting on issues. Yes, there's some statements about what some of the scientists are concerned about, and there are real fears there. But as I might remind you, I'm doing about half of my work right now involved in helping employers get their employees back to work. I'm very much aware of the economic pain that's going on out there. We're feeling some of it as well. We're, in terms of upcoming videos, because of a lot of different things going on. Major one being pulls in terms of my time, focus in terms of my time on helping folks get back to work. We are going to be decreasing the frequency of these COVID-19 YouTube lives. We also think that it's become much less of an emotional, fear-based issue. It's become much more of a political issue at this point, and politics is not really the purpose of this channel. The purpose of this channel is to help people focus on the things that cause death, disease, and disability, and specifically the ones that are preventable. And so we will continue to do YouTube lives. We're going to be getting more YouTube live topics back in terms of cardiovascular prevention, pre-diabetes detection and prevention, things that will help you in terms of prevention of COVID-19, if and when you get infected with SARS-CoV-2. So we'll be continuing to do that. We've got plenty of topics, more than enough. We had one viewer say, gosh, I'm so sick of hearing about COVID-19. Let me tell you, I've been sick of hearing about COVID-19 for weeks and weeks and weeks. I think we all are. Who is not sick of it? Again, we're going to continue to provide information that we do feel folks need to protect their health. We've covered other updates, the emergency use and authorization of remdesivir, the vital patch for things like hydroxychloroquine and COVID-19 itself, the at-home test kit, the EUA for that, authorized on May 16th. The statements back and forth about the Roche 100% accurate tests. I'll believe it when I see it. I have no doubt it's a good test. Probably a significant improvement. Well, clearly a significant improvement over the vast majority of what's out there, but I've never seen a perfect test. It's been approved for use in the UK for their testing program. Other items, an alert on the Abbott test that got a lot of positive reviews coming out of the blocks. There's some questions, which again, you would expect as a test starts getting more and more use. Some of the questions have to do with, was the sampling done correctly? So not defending the test, I'm just saying it's going through its challenges right now. It's what we would expect. We've covered items like New Zealand, 100 cases total for the whole country. It's a small country, but that's not the issue. They've been very aggressive with their lockdown. So aggressive lockdown works, but again, I haven't heard anything about New Zealand's economy. Questions about which body fluids contain SARS-CoV-2. And I was having this conversation with Janice yesterday, and I was saying, I don't know how to get the point across. It's sort of like the old question about, well, is the flu spread in semen or sweat? And nobody really ever asked the point, because you got to get through all of those plumes of flu virus before you ever get to the semen and sweat. So same thing with this. There are so many proven methods of infection through the air. Again, there are only special use cases where you would need to know about risk from sweat, semen, urine, things like that, but you haven't already gotten significant exposure through the air. So yes, that kind of information will come out, but on a practical basis, that's really more for healthcare providers than most of the rest of us. Again, we're still providing some. We're busy, but we are providing some access to urgent care, specifically focus. Got several different options on helping you look for unrecognized prediabetes. The vast majority of us, as we look at our risks of getting disabled, our risk of dying earlier than we need. Yes, COVID-19 is an issue, but COVID-19 is very much related to the same risk factors that heart attack and stroke are. All of them, prediabetes. And the vast majority of prediabetes is unrecognized, over 90% of it. We've already documented. It's very, very clear. Your typical primary care doc does not know how to diagnose it. We have methods, and we're very comfortable sharing those. If you've got a CIMT that you haven't had interpreted yet with a doc, we can do that. And again, don't depend on a stress test to predict whether or not you're going to have a heart attack. Too many people have done that. Too many people have died. We'll keep you posted on the book. Today we're going to be talking about how to get back into the work world and how some things to be thinking about in terms of reopening, right after Carl gives us the water ball. So this article was in the New York Times. As many of you would know, there always tends to be a spin. New York Times has always tended to be leaning on maybe one area of the political focus. We'll cover that. We'll also have some statements on both sides. For example, dozens of states seeking to ease the pain of working people and small business owners are coming out of lockdowns as of last week. But most of these states have not yet met even the minimal criteria for coming out. Again, for coming out safely. And again, you got to ask the question, why? Go back to the first statement, the pain associated with the economy. Some, in fact, a lot are even reopening as cases in those states and towns continue to rise. Continue on the uptick. Texas, for example, has seen a steady rise in cases and fatalities since reopening just over 2 weeks ago. While the 45,000 plus cases in Texas are still well below New York's 345,000 plus, the steady increase shows that the curve has not yet begun to flatten in Texas. Scientists say a much feared second wave of infection may not wait until fall, and instead may become a storm of wavelets breaking unpredictably across the country. The effects of the reopening, though, will not be immediately apparent. As we know, it takes 2 or 3 weeks to start to transition from newly infected cases to severely ill, hospitalized, and death rates. But can the U.S. minimize the damage? There are certainly things to think about, and let's get into some of those. Social distancing, physical distancing, has proved effective at interrupting viral transmission. So yes, you can get out into the workplace. Consider things, though, where you can in terms of continuing physical distancing. Again, where you can. Masks worn in public places by everyone are far more effective than was previously realized. In an open letter to state governments, this practice is even supported by 100 experts and medical professionals. So, no, we didn't wear masks in the U.S. prior to 2 to 3 months ago. You saw it in other countries. You didn't see it here. Now you're seeing it here. And now you're seeing a significant number of experts saying, you know what? It matters. It makes a difference. Wear your masks. Number 3, testing remains inadequate. There's no question about that. Home use nasal swabs, saliva tests are on the way. Much higher accuracy tests are on the way. We mentioned this Roche test that's supposed to be, quote, 100% accurate. I will tell you, I'm working with the work that I'm doing for employers. I'm working with several of the groups that are working on very, very detailed antibody tests, not just a plus or a minus, you're infected or not, but what is your actual titer? What is the portion? How much antibody have you created? And not only that, what type of antibody? IgA, IgM, IgG, and all of those things matter. The titer is not an unprecedented thing. We've done that in several types of infectious diseases. One of them, for example, being syphilis. We've done that for decades. Gosh, well over 40 years, we've looked at syphilis titers. So, you know, some of this is getting back to things that we've done in the past. Employers are moving to design safer workplaces. Again, as I can tell you, one of the major criteria that we work on with employers as we get involved in this activity is, okay, how do you reconfigure your workplaces? There's a lot of discussions about putting up dividers in rooms and what kind of dividers work. There's a lot of discussions. We've got some employers who are in the New York area that have a lot of large rooms with cubicles. And again, not only using cubicles, but saying, okay, who has to come back? Who really needs to come back, and who can continue to stay at home and work? So how much distance can we get between the people in these rooms? A modestly effective antiviral treatment, remdesivir, as we've mentioned many times, has been found. And again, there's use that's increasing with remdesivir. And don't get me started on hydrochloroquine. Labs around the world are racing toward a vaccine at an unprecedented pace. Also, mRNA, or as others call it, Moderna, announcing some positive impact from their virus vaccine. While it may still be possible to blunt the impact of the reopenings, things still remain difficult. Here are some reasons. Deaths are already far higher than the 60,000 once predicted to have happened. Excuse me, easy for me to say, huh? The 60,000 once predicted to have happened by August. We've already blown through that. Americans are already struggling to stay at home or remain 6 feet apart on crowded beaches, hiking trails, park playgrounds. Again, you already see significant evidence of just not following the mask rules, not following the 6 foot rules either. And the 6 foot rules are very, very aggressive or conservative, depending on your perspective. As we work with employers, it's really clear. A lot of employers say, okay, as long as you're 6 feet apart, you're safe. No, not at all. In fact, the evidence would indicate 6 feet is a bare minimum. And it really is focused on a time perspective too. That 6 feet is based on an assumption that there's no more than 10 minutes exposure at that time. Social distancing has dropped by 17 points since late March, as several states have ended stay-at-home orders, according to a new Gallup poll released on May 15th. Outside New York, California, and a few other states, many Americans continue, as we mentioned, to refuse to wear masks. Some places, anti-lockdown protesters are even spotted with slogans like, "Be more like Switzerland," "Fake crisis," and "Heck with all this, let's get back to work." Testing and tracing remains a sore point, contact tracing. While 50 brands of antibody tests were available, many are inaccurate. In case contact tracing will be automated, many Americans are unlikely to accept that and are, again, already raising red flags about more impingement on social freedoms. There have also been new hotspots in meat and poultry plants, veterans hospitals, nursing homes, while the number of cases in rural states like, I think that's Iowa, Arkansas, Minnesota, South Dakota, Virginia, are still substantially lower than early epicenters, New York, Massachusetts, and New Jersey. They're growing at a faster rate now. So again, until you've been there, until you've seen people actually dying, even though you may have heard about it in other places, it's very difficult for it to become a reality, especially when overcoming the financial struggles that are occurring. Financially, struggling hospitals in rural states often have few ventilators, and ambulances must drive patients to a longer distance. With such a situation, obviously, lives can be lost in terms of getting that patient to the needed, necessary care. Carl, do you want to play the video on this second wave?
Scientists and doctors are warning of a possible second wave of COVID-19. When that could happen and what it would look like are the biggest questions. Dr. Peter Marks, director of the Center for Biologics Evaluation and Research at the Food and Drug Administration, says a second or even a third wave is, quote, not unlikely. Marks said it will be an ongoing concern until a vaccine is developed. Until widespread testing is available, experts may not know if people are immune to COVID-19 if they've already had it. Possible second wave. Experts believe the second wave will likely hit areas not as severely infected now. Dr. Gregory Poland of the Mayo Clinic says, quote, Wave 2 will be in the interior of the country, where there are a lot of susceptible people. It's unknown how the virus will act in warmer weather. If it behaves like the flu, it could survive longer in colder, drier weather and reemerge in winter. More widespread testing is necessary to answer these questions.
So in case you hadn't noticed, we've transitioned from the program to the Q&A. We're going to try to keep the Q&A to a shorter amount this time. Dave Murphy, super chat for $5. Thank you so much, David. Again, it means a whole lot for our team, for folks to go out there and say, look, I'll contribute something from my own, something of my own to help move this, this effort forward. And again, the effort is to help folks understand what's, how to prevent what's killing and disabling us. Jim D, the real question is, will we ever again be able to get back to, quote, normal, end quote, or is this a whole new era of new normal, where all the mom and pop retailers and shops can no longer make it? I think that is a very important question. And I do. I think that's such a critical question. I'm running my own small business now in my retirement. Probably at least half of my patients, maybe 2/3, are in a similar situation where they are running their own small company, their mom and pop shop. Some of them are retailers. Most of them, a huge number of dentists. And dentists have, I just got off the phone with a dentist patient who, again, said we have still not gotten back to break even yet. We are still bleeding cash. And it's a major, major problem. Dave Murphy, 97%, 69 beats per minute. Thank you so much, Dave, for sharing that. Farouk Farr. Farouk, haven't heard from you in a while, Farouk. Farouk is in Iran and shared with us some of the death and devastation he saw early on. As you may remember, Iran was one of the first nations to just get really hit hard. Farouk lost a friend, I think a young, healthy male cousin at a time when many of us were saying, look, it's just not hitting young, healthy people. And he said, yes, it is. In fact, I just lost a family member. Good morning, Farouk. The government opened here in Iran. Numbers are going up. Patients which discharge from hospital with no symptoms will return to hospital in 48 hours with all the symptoms. Thanks for sharing that, Farouk. And yes, so there's no question there is a significant risk, but again, the question is, I'm not going to deal with the political questions of what to do. I'm dealing more focused in how to do what we do safely. Bart Robinson, good morning, everyone. Hope all is well. Good morning to you, Bart, I'm sorry. And we hope you're well as well. Sax Girl, how about public bathrooms? No sweat, maybe no other people, but bodily wastes aplenty. That is a really good point. And as many of you have seen, there's been a lot of focus on aerosolization of feces when you flush commode. For that reason, we've been avoiding public commodes as much as possible. Every week or two, we'll make a trip over to Louisville, which is about an hour away, to see our son. And he walks on one side of the road, we walk on the other and talk from a distance. But it's great to see him, and it's clearly worthwhile. The reason I brought that up is that both Janice and I make sure not to have much to drink or to eat for a few hours before we go over there, for this very reason. Don't want to be caught outside of our home and having to go to the bathroom for the exact reason you're talking about. Concern about aerosolization of fecal matter in a public bathroom. James Cantor, my doctor and I did discuss pre-diabetes. Still, I progressed to diabetes in a few years. James, thank you so much for sharing that. You know, one of the things we keep warning people about is they don't know about it, they don't think about it, and their doc is not likely to think about it. Well, as you point out, a lot of docs do know what they're talking about in terms of prediabetes. Certainly not the majority. That's a problem, which will get fixed some point. But that doesn't stop the progression. People think, you know, why are we seeing so much diabetes and prediabetes? Is it all the obesity epidemic? Obesity clearly drives it. But think about it. When have we always felt like it was just a natural thing to expect to have a heart attack or stroke in your 60s and 70s? Not in your 30s, even though you're obese, in your 60s and 70s. And that's because aging is by far the major driver for prediabetes. As part of aging, our insulin receptor in our muscle and liver cells begins to lose function. So here we go. Thank you so much, Lori. Hi, everyone. I'm Laura Lynn Lictoa, but you can just call me Lori. I'm the nurse educator with PrevMed. So if you have any questions or concerns, contact me at 859-757-2324. That's 859-757-2324. Thank you very much, Lori. And Janice and Michelle and I were just talking about your plans to go ahead and get that information out there. Mike Martyr, worst thing, take both tests. Do you have a test and antibody? Did you have it? And but find out you were sick. 10 weeks, but COVID-19 negative. Positive gets some level of immunity, Fooey rats and double rats. I think what you're saying, Mike, is you find out that you did have some, you've got evidence of infection, as with an antibody, but you did not have the COVID-19. And Bart, I'm sorry, I don't know. I mean, Mike, I don't understand exactly what you're saying. It sounds like you're saying you find out you have a positive antibody test, but you did not get COVID-19, the serious infection associated with SARS-CoV-2. In other words, you just got some infection. I will tell you this. Number one, that's actually a lucky place to be, especially for baby boomers, to have found out that you did have the infection and you did not get full-blown COVID-19. That is the risk. That is the problem. I'm not too worried about this some level of immunity issue. Yes, there is significant evidence that immunity is not complete and 100%, but I'll take 80% any day of the week, especially for this infectious agent as well as others. Is it 80%? Is it 90%? I'll take partial immunity anytime. So maybe I just didn't understand you, Mike. Jim D, is it nature that is pushing us into a cyberspace virtual social context akin to house arrest, or is it contrived? This is the question. Well, it's an interesting thing. If you start looking at and studying history, there's no question that man has dealt with these issues multiple times in the past. The Black Plague wiped out, what, half of Europe? Waterborne diseases continue to happen in this country. Not so much here, but they still happen in other areas. It wiped out major portions of Lexington. I've got videos on that in the past. If you read the book Guns, Germs, and Steel by Jared Diamond, he makes a really good point that it wasn't quite so much military tactics that the Europeans used when they conquered the American native. It was guns and steel, but again, germs. The germs they brought over helped wipe out the existing populations. Getting introduced to new bugs is not a new thing for humans. And significant, here's what's new: our lack of tolerance as a culture, as a society, to tolerate the number of deaths. Now, I think in the past, had we known how to decrease the number of deaths, we would have made efforts to do that. But it's not at all a new thing for us to get infected with killer bugs. Karen Black, Doc, I think that artemisinin has been used to treat fever for 2,000 years and is effective in treating malaria. Could it be an alternative to hydroxychloroquine with zinc, of course, as an early treatment? I don't know. I've heard of artemisinin. I've heard of its use in fever. My question for you, though, is hydroxychloroquine and zinc, are they really just dealing with fever, trying to bring down the fever, or are they decreasing? Is the attempt there to decrease the actual virulence of the infection? That's really the question, I think, not so much managing the fever. Good morning. We see cases in Iran. This is Farag Far again. We see cases in Iran where the patient was discharged from the hospital with no symptoms and returned in 48 hours with most of the symptoms. Yes, that's not unusual, Farag. That's one of the surprises that people got with this disease. They thought people were just fine. And then, again, with the same scenario, would send people home, and then they'd come back, sometimes in a body bag, or come back in extremis, in major distress. And that's one of the things that folks have been saying in terms of monitoring that O2 saturation. Use these pulse oximeters, especially do it on a regular basis to make sure that you know what your normal pattern is. For most of us that are healthy, it's going to be 96, 97, 98, 99. If you get if you get SARS-CoV-2 infection and suddenly you start dropping, you need to let your doc know that. And if you drop low enough, don't worry about calling your doc, just get into the ER. That's one of the areas where people are getting deceptive, but again, there are other areas as well. Thanks for reinforcing that, Farouk. Bob Cipolla, if you've had COVID-19 and developed antibodies and are now approximately 10 weeks out, can you still pass the virus via respiratory route? That's really a great question. So anytime they can grow the virus through the PCR, through the viremia test, yes, you can pass it. However, it's not quite that simple. You're much more likely to pass it if you're those, week 1 and 2, 5 days into your infection, and you don't have any antibody whatsoever. At that point, again, you're spewing a lot more virus. I think it stands to reason, and it's true. The more virus the more of any infectious agent that you're spewing, the more contagious you are. Jim D, that was good info about it being a matter of time and space. No one has ever mentioned that there was a 10-minute presumption in the guidelines. Well, I appreciate you sharing that, Jim. And yes, that's some of the stuff that we picked up in terms of studying and helping employers in terms of return to work. Bob Cipolla, if you've had COVID, I think we just covered that. At Rob, great call on the back to basics in the prevention topics. I miss you talking about health. Enough COVID-19. Let's focus on our health and well-being. Thank you, Dr. Brewer. Well, thank you, at Rob. And, we never would have gone here had COVID-19 not been a major, immediate, and permanent, and not so permanent determinant of health. So we'll continue to cover it, but thank you for your support on that decision. Farouk Far, I miss your your shaky paper. Well, thanks. I appreciate the comment. You're not the only one that misses it, and occasionally we'll do it just for good old time's sake. Karen Black, my office building does not have fresh air intake for HVAC and no vents in the bathrooms. I am worried that any contaminated particles will be recirculated throughout our offices. Interesting question, and I haven't gotten there yet. I don't do that much of the physical design piece, but that's a very interesting question, Karen. Thank you for bringing it up. Bart Robinson, I trust the wisdom and opinion of Michael Levitt from Stanford University and emergency room doctors in the Bronx more than any government so-called health expert. Thanks, Bart, for sharing. Emma Zahn, why is the virus worse in the winter and lesser in the summer? Thanks loads, Dr. Brewer. You see this with what we, the respiratory diseases. Nobody knows for sure, but I think most of us have our suspicions. Mine, for example, is this. In the colder environments, most of us put heat in our house. Well, if you have even 30 or 40 degrees outside, but 70 degrees inside, you're heating air that only has the moisture that a 30-degree air can hold. So guess what? It dries out your mucous membranes. And we all know that. Many of us even get bloody, dry bleeding of our mucous membranes during the winter. Guess what? One of the most important components of our immune system in terms of fighting infections for respiratory infections has to do with having moist mucous membranes. As we lose the moisture of our mucous membranes, we lose one of the most important defense mechanisms. So that's number one. Then number two, if the majority of us lose our most important defense mechanism for respiratory infection, that means a lot of us get infected. So we get a double whammy in terms of a population, and that's exactly what people are concerned about with going into next winter. I tend to feel like that whole concept has been is unproven yet in terms of COVID-19. I tend to be a little bit more concerned about the many waves of many outbreaks that we'll see even during the summer. But again, that's we're going to find out a lot more about that as we experience the next month or two. Bart Robinson, Rob, I agree. Dave Murphy, Ivor Cummins said his research of prior COVID virus shows they all died down in the summer and then ramped up again in the fall. Predicts this will probably do the same. I hope there is a significant die down this summer. For reasons that I mentioned, I do expect it to be there to be increased risk during the fall, but I don't expect us to suddenly go to few, if any, infections just because it's the summer, as we start ramping up, getting people back in and on a systems-wide basis, decreasing the physical distancing that we've been doing. Physical distancing has mattered. Joe Riley, thank you, Joe, for $5 super chat. 97%, 70 beats per minute. And again, thank you, Joe, for suggesting that we cover the O2 sats, the pulse oximetry. Jose Fontal, weird times we live in when a doctor, Fauci, has more power than the president. He can even tell you not to go to the beach or gym or stores, and you have to obey. You know, Jose, that's not so much weird times. I mean, it's yes and no, but I remember when I found that out personally when I was doing some work with the Department of Public Safety with flu vaccine, and then with other employers with flu vaccine. But this was like 30 years ago when I was at Hopkins doing some consulting, and the commissioner of the department turned to me. We were talking about that year's flu. And he turned to me and he said, Doc, you may not understand this, but you've got more power than I do. I can move things around on a daily basis, but you can shut us down in terms of the flu and infectious diseases. So that's always been there. It's just that we tend to not notice, and the public health people tend to stay very much in the background with large horn-rimmed glasses on with our heads stuck down in papers until and unless something like this happens. Thanks for the comment, Jose. Bart Robinson, Ivor Cummins just had a good discussion with Mike Levitt. Bart, I don't have much confidence in Dr. Fauci. Fauci's been out there too far for a lot of people's taste, but you know what? There's been a lot of need out there as well. COVID-19 GMD, COVID-19 situation is waking common folk up to important questions. One, should we be doing blood injection vaccines around natural autoimmune pathways? And two, what's going on in the bio labs? I'm not too clear on the first question. And actually not that clear on the second question either. I think I understand what the questions are, but really don't have a whole lot to add to to trying to answer those. Thanks, Jim D, for the contribution, and thanks to the rest of you for your interest. So we will have another. We will be having our dailies tomorrow, Thursday, and Friday, and then after that, after Fridays, our next one will be the following Wednesday. Thank you so much for your interest, and stay safe out there.